Welcome to today's deep dive. When you take your car to the mechanic because it's making this, like, just a terrible noise, there's usually this expectation of precision, right?
Oh, yeah. I mean, it feels like engineering. We crave that clean categorization.
Right. The mechanic just, plugs a little computer into the dashboard, reads a code, and says, aha, your transmission is failing. Or maybe, no worries, it's just a loose fan belt.
Right, which to the untrained ear, they both just sound like an absolute disaster under the hood.
Exactly. But the underlying mechanisms and, more importantly, the fixes are completely different. And the thing is, the moment you step into the world of musculoskeletal medicine, it's like that diagnostic computer is just completely broken.
It really is. We want things to be, visible and instantly solvable with a quick scan, but the clinical landscape here is notoriously murky.
Which brings us to our mission for today. We're going to turn you, the listener, into a medical detective. We're decoding the hidden language of joint pain.
Yeah, we're pulling from a whole stack of really fascinating clinical case files and medical teachings to show you how doctors differentiate between entirely different types of pain.
Right, and using surprisingly simple clues. Because, why should you care? Well, musculoskeletal complaints are, like, incredibly common.
Oh, they're some of the most frequent reasons people seek out medical care, actually.
Yeah, and understanding the subtle difference between, say, my joint hurts and the tissue surrounding my joint hurts, I mean, that completely changes the diagnosis.
It changes the treatment pathway, and ultimately, it changes your quality of life.
Right. So we are going to look at how that differentiation actually happens at the bedside without just immediately defaulting to a $1 million MRI machine. But to start, we kind of have to talk about why the foundational textbooks sometimes lead clinicians completely astray.
Yeah, they really do. Because in theory, diagnosing inflammation should be a relatively straightforward checklist.
Right? Shouldn't it be? I mean, I'm going to push back on this right away. If you open a medical textbook, you get the 5 classic signs of inflammation, right?
Yes. They are literally drummed into medical students from day one. Redness, heat, pain, swelling, and loss of function.
Okay, so if those are the time-tested signs, shouldn't they just work? Why are we dedicating this entire deep dive to rethinking them?
Well, because the physiological reality of a human being is just, it's infinitely messier than a textbook diagram. Relying solely on those visual classic signs will frequently lead you right into 2 major diagnostic traps:
And those are?
false positives and false negatives.
Okay, let's break those down because that gets to the core of the biology here.
Yeah.
Start with the false positives. How can a joint look legitimately inflamed but, not actually be driven by an inflammatory disease?
So the prime example from our sources is osteoarthritis. Mechanically speaking, osteoarthritis is a non-inflammatory condition.
Right, it's more of a structural thing, isn't it?
Exactly. It's traditionally understood as structural failure, just the wear and tear, degradation of the cartilage over time. But because that cartilage is breaking down, you get this bone-on-bone friction.
Which causes irritation.
Right. It creates secondary, localized mechanical irritation in the joint.
So the joint is reacting to physical damage, not like a systemic immune attack.
Precisely. And because of that localized irritation, a patient with osteoarthritis can present with joints that are noticeably swollen, they're tender to the touch, and they're functioning poorly.
Okay, so you have pain, swelling, and loss of function. That's 3 of the 5 classic signs right there.
Exactly. But the underlying systemic driver is not an autoimmune inflammatory disease. The visual evidence just mimics it. So if a doctor just goes down the checklist without understanding the mechanism, they might miscategorize a structural wear and tear problem as a systemic inflammatory disease.
Wow, and then prescribe entirely the wrong class of medication. Okay, so the false positives make total sense.
Yeah.
What about the false negatives? Because that seems, honestly, even more precarious.
It is.
Having an active systemic inflammatory disease, but failing to show those textbook signs?
It happens incredibly often, actually. Inflammatory joint diseases frequently lack obvious redness or warmth. And part of this is just, simple anatomical geography.
Like where the joint is located.
Right. The joint might be deeply seated, like a hip or a shoulder, where layers of muscle and tissue completely mask the heat from the surface of the skin.
Oh, wow. So you literally just can't feel the heat through all that muscle mass.
You can't. Furthermore, erythema, which is the clinical term for redness, can be genuinely difficult to detect in patients with darker skin tones.
Right, of course.
The vascular dilation is happening underneath, but it isn't projecting that classic bright red signal to the naked eye.
Right, so if a clinician is rigidly waiting to see red skin, before they diagnose inflammatory arthritis.
They are going to miss a significant number of cases, which delays crucial treatment.
So our eyes can just completely deceive us. The classic signs are structurally unreliable.
In a routine clinical setting, yeah. But there is this one fascinating exception mentioned in the case files that is dramatic enough to be diagnostically undeniable.
Oh, the medical outliers are always the most revealing. What is the exception?
So it occurs in cases of highly intense acute inflammatory arthritis. Specifically, the sources note acute sarcoidosis around the ankles or acute gouty arthritis in the feet.
Okay.
In these specific hyperintense cases, the inflammatory fluid buildup is so severe that as the inflammation finally starts to subside, the outer layer of the skin actually peels off.
Wait, it just physically sheds. It's like a
Oh.
bad sunburn.
Very similar visually, yeah, but for a totally different mechanical reason. The medical term is desquamation following indurated inflammatory edema.
Okay, let's translate that out of textbook speak for everyone. What is actually happening to the tissue there?
Think of the skin getting so rapidly engorged with inflammatory fluid, the edema, that it stretches drum tight. It becomes hardened and indurated. The blood vessels are incredibly dilated. The tissue is stretched to its absolute limit, and as that massive fluid wave finally retreats, that overstressed outer layer of skin simply dies and sheds.
That is wild. That physical shedding acts like a receipt that a massive inflammatory event just took place.
Exactly. It tells you exactly how extreme the underlying vascular changes were.
But obviously, we can't count on the skin peeling off every time, right?
Yeah.
And since relying purely on the visual classic signs and how that... Okay, let's unpack this. If we can't trust our eyes, what are we actually listening for?
Right.
How do we build a reliable framework for spotting inflammatory disease?
This is where we shift from looking at the joint to listening to the mechanism of the history. Our sources lay out a specific cluster of clinical features that reliably distinguish inflammatory from non-inflammatory disease. And it relies on 4 distinct pillars.
Okay.
The first pillar is time.
Time. Were we talking about like time of day or the duration of the pain?
We are talking about the duration of a very specific physiological symptom, which is early morning stiffness.
Okay, tell me more about that.
In inflammatory joint disease, a patient will wake up stiff, and it takes at least 30 minutes for them to reach maximum improvement. But, more often than not, it takes closer to a full hour of them being awake and moving before that stiffness finally subsides.
We need to explain the biology here, though. Why is the time limit so specific? Like, why a full hour instead of just 5 minutes of feeling creaky when you get out of bed?
It comes down to what we call the gelling phenomenon and also the circadian rhythm of the immune system.
The gelling phenomenon.
Yeah. While you sleep, you are relatively motionless, and inflammatory marker cytokines actually peak in the early hours of the morning. So this inflammatory fluid is actively being produced, and because you aren't moving, it pools and thickens inside the joint capsule.
Oh, so it literally gels.
It literally gels. It takes an hour of movement to physically flush that thickened, cytokine-rich fluid out of the joint space.
Which perfectly sets up the second pillar then, which is movement. Because this is a fascinating paradox, right?
Oh, absolutely.
In inflammatory disease, gentle activity actually improves the symptoms.
Right.
Conversely, inactivity makes it worse. Like sitting still for a 2-hour movie allows that fluid to pool again, and the stiffness just creeps right back in.
Precisely. The mechanical action of moving the joint acts like a pump, utilizing your venous and lymphatic drainage to clear out that inflammatory fluid.
It's the difference between a rusted hinge and a frayed rope.
That is a great way to put it.
Yeah, like a rusted hinge needs to be worked back and forth to loosen up, right? That's our inflammatory disease. But a frayed rope just gets more painful and damaged the more you pull on it.
That analogy captures the mechanics perfectly. The rusted hinge improves with motion. The frayed rope, which is the non-inflammatory wear and tear, worsens with motion.
Makes total sense.
Now, the third pillar of our framework is unpredictability. Inflammatory diseases feature spontaneous flares.
Meaning there's no mechanical trigger.
Right. The patient will experience an up and down fluctuating course of pain and swelling without any obvious external cause, like they didn't run a marathon, they didn't twist their knee on the stairs,
The autoimmune disease just decided to flare up on a random Tuesday.
Exactly. And that leads to the fourth pillar, which is the systemic clues, the constitutional symptoms.
Right. The sources mention severe fatigue, fevers, night sweats, and unexpected weight loss.
Yeah.
But let's clarify the mechanism here, because the old analogy is that the immune system is running a marathon in the background.
Mhm.
But I don't think that quite fits.
No, it doesn't.
It's more like a house with a broken thermostat.
Right.
The furnace is running on high, heating up the entire house, causing the fever, the fatigue, the night sweats, even if it's only one door hinge in the basement that's actually squeaking.
That is a perfect way to look at it. The inflammation is systemic, driven by acute phase reactants circulating in the blood, so the entire body feels the heat, not just the localized joint.
Got it.
So, to recap those 4 pillars for inflammatory disease: morning stiffness lasting over 30 to 60 minutes, the paradox of improvement with movement, spontaneous unpredictable flares, and systemic symptoms like fatigue and fever.
Okay, so if that is our rusted hinge, what does the frayed rope look like? How does non-inflammatory disease present across those exact same 4 pillars?
Well, it is the exact mirror image. Early morning stiffness, usually under so many minutes, often resolving in just a few minutes once the mechanical joint gets moving.
Right.
Movement. Pain is provoked by moving the joint rather than improved by it. When they rest, it feels better.
Right.
Flares. Highly uncommon, unless there is a clear mechanical trigger, like they walked 5 miles on a bad knee. And systemic symptoms. Completely absent. The thermostat is normal. If you ran their blood work, their inflammatory markers would be completely unremarkable.
It really is an elegant mirror image. But, I mean, knowing how tricky human biology is, there has to be a catch, a scenario where the framework seems to break down.
There is a crucial caveat, yeah. And it serves as a massive safety net point for clinicians. In some of the most common inflammatory diseases, specifically rheumatoid arthritis and psoriatic arthritis, the joint might look totally quiet on a physical exam.
Wait, how is it biologically possible for a joint to be actively inflamed but not look swollen or feel hot?
Because the inflammation in these conditions might be heavily cellular rather than purely fluid-based. You can have a proliferation of the synovial lining itself, a thickening of the tissue called pannus, without a massive outpouring of fluid into the drain space.
Oh, so the biological process is raging, but it's not producing the water balloon effect that the naked eye can actually see.
Exactly. And this is why the sources stress that the patient's history drastically outranks the physical exam findings.
History over physical.
Every time. If the patient tells you they have an hour of morning stiffness, gentle activity helps, and they wake up drenched in night sweats, but their joint looks perfectly normal to your eye, you trust the history. Do not let a clinically quiet joint fool you into missing a systemic inflammatory disease.
Here's where it gets really interesting, because now we have a solid framework for what the problem is, systemic inflammatory versus mechanical non-inflammatory. But how do doctors figure out exactly where it is?
Right.
Because we need to separate true joint pain, which the sources call articular pain, from pain in the surrounding structures. Right? The periarticular or soft tissue rheumatism.
This is a vital distinction because the treatment pathways are entirely different. You really don't want to prescribe a heavy systemic immunosuppressant for like a localized tendon issue.
But how do you test this without X-ray vision? I mean, how do you distinguish whether the pain is originating inside the tiny sealed capsule of the joint or in a tendon attaching just a millimeter next to it?
Well, the clinical files outline 4 specific bedside checks to isolate the anatomy. The first is inspection, looking closely at the specific shape of the swelling.
Okay, what shapes are we looking for?
If the swelling is globular or fusiform, meaning it symmetrically surrounds the entire joint like an inflated water balloon, that points to an articular problem inside the joint capsule.
Because the joint capsule itself is a closed system. So if fluid fills it, it expands outward uniformly in all directions.
Precisely. But if the swelling is localized specifically to one side or just one specific bump around the joint, that points to the soft tissue like an inflamed bursa or a specific tendon sheath.
So symmetrical balloon versus a lopsided bump.
Exactly.
What's the next check?
Palpation. Where exactly does it hurt when you press? If there is tenderness right along the joint line margin, often accompanied by a grinding feeling called crepitus, or palpable fluid inside the joint, that means the pathology is articular.
Okay.
But if the tenderness sits distinctly away from the joint margin, out in the surrounding muscle insertions, it's soft tissue rheumatism.
Okay, so where it hurts is where the problem is. But the third check is the one that really highlights the mechanics of the body, I think. Movement, active versus
So
passive.
this is the definitive distinction, yeah. Articular disorders, true joint capsule problems, impair both active and passive movement equally.
Let's make sure we frame this correctly for you listening. Active movement forces those surrounding tendons and muscles to fire to move the limb, right?
Yes.
But passive movement, when the patient completely relaxes and the doctor just moves the limb for them, that bypasses the muscles entirely, isolating the joint capsule itself.
Correct. So if the hinge itself is broken, The true articular joint, it doesn't matter who is moving the door. Whether the patient fires their muscles or the doctor does the work, the internal capsule is still grinding. Active and passive movement are equally painful and restricted.
Well, with soft tissue.
With soft tissue rheumatism, the joint capsule is completely fine. The problem is in the hydraulic closer attached to the door, so to speak, the muscles, tendons, or bursae. So pain is specifically worse on active movement. It hurts significantly more when the patient tries to move the joint themselves because they're actively firing off those damaged surrounding tissue.
Right. But when the doctor does it,
When the doctor takes the weight and moves it passively, the patient's muscles remain relaxed and the pain is vastly reduced.
that is such a clever mechanical isolation. You're literally testing the individual components of the body's machinery just by shifting who does the work.
It's elegant. And the fourth check is a therapeutic clue.
Okay.
If a doctor administers a highly localized corticosteroid injection, it tends to produce dramatic, almost immediate relief, specifically in soft tissue rheumatism. If the severe pain vanishes after a targeted injection to a tendon sheath, you know you've hit the right localized target.
And it proves it wasn't a systemic joint issue.
Exactly.
Let's put this into a real-world context for you, the listener,
Yeah.
because we're talking about soft tissue rheumatism a lot. But what do these actually feel like in daily life?
Oh, they are incredibly common. They make up a huge chunk of outpatient clinic visits. We're talking about frozen shoulder, also known as adhesive capsulitis, where the connective tissue tightens up.
Right.
We're looking at lateral epicondylitis, which most people know as a tennis elbow, various bursitis syndromes in the hip or knee, de Quervain's tenosynovitis, which causes severe pain at the base of the thumb.
So a patient might come in terrified that their elbow joint is, like, decaying, when in reality it's just the tendon insertion point that's inflamed.
Exactly. They are periarticular. But if the doctor doesn't deliberately isolate the anatomy using those four checks, the shape of the swelling, the specific line of tenderness, the active versus passive movement, and targeted injections, they can easily mistake a simple tennis elbow for a degenerating elbow joint.
Okay, so we have a pretty deep understanding of these micro clues now. We know the cellular reasons behind morning stiffness, and we know how to mechanically isolate the soft tissue.
Right.
But zooming out, if you are a doctor and a patient walks in just saying, I just hurt all over, how do you survey the whole body without getting lost in the weeds on the very first joint?
You need a rapid systemic screening tool. And our sources provide a standard from the Vault of Clinical Skills, which is the GALS screen. GALS. It stands for gait, arms, legs, spine.
It sounds like a quick sweep, but what is a doctor actually looking for when they run this screen? Like, make us visualize it.
Well, it is designed to be a highly efficient way to screen the entire locomotor system in just a couple of minutes. First, gait. The doctor literally just watches you walk across the room.
Simple, no?
They are looking for antalgic gait. Are you favoring one side? Is your stride symmetrical? Does your pelvis tilt abnormally?
It's the most basic functional test. Like, can the machine move forward smoothly?
Exactly. Then, arms. They'll have you put your hands behind your head to check external shoulder rotation, then have you hold your hands straight out, turning the palms up and down to check pronation and supination of the elbows and wrists.
And they check the hands too?
Yeah, they'll quickly squeeze the knuckles to check for hidden tenderness.
Okay, and the legs and spine.
For legs, they are checking hip flexion and internal rotation, which is often the first thing to go in hip disease. They'll press on the knees to check for effusions, fluid buildup, and inspect the arches and toes of the feet.
And finally, the spine.
Right. They'll watch you bend side to side to check cervical rotation and touch your toes to observe lumbar flexion. It visually maps out where the mechanical roadblocks are before the doctor commits to a microscopic exam.
But as we've established, the physical exam, even a great comprehensive screen like GALS, is only half the battle.
Barely half.
Right. We have to apply our time and motion framework to the history. And there is a fantastic case study in the sources that brings this all together perfectly.
Oh, I love this case study.
Yeah, I have it right here, and I want to test you, the listener, to see if you can spot the physiological clues.
Okay, lay it out.
Picture a patient sitting in the clinic. Her primary complaint, the thing she emphasizes above all else, is that the worst part of the day is the morning.
Which should instantly trigger the first pillar of our framework.
Exactly. She describes a very vivid physical sensation. The sources refer to it as a pattern that is a sound, not just a shape. She says she tries to make a fist first thing in the morning, and her hand simply won't close. Not because a sharp stabbing pain stops her, but because the whole hand feels swollen from the inside out. She describes the tissue as feeling thick, unwilling to move, almost like it's encased in something heavy.
Okay, so what does this tell us mechanically? We have to ask the critical question based on the circadian pooling of those cytokines we talked about earlier.
Right. The doctor asks, how long does it take for your hands to loosen up? And the patient's honest answer is, over an hour.
Boom. Pillar 1 confirmed. Early morning stiffness lasting more than 30 to 60 minutes. The gelling phenomenon is highly active.
But the clincher comes next. Her husband is in the room, and he drops a crucial, completely unprompted detail. He says, she is always better by lunchtime, most days, when she's up and moving around the house.
Pillar 2 confirmed. The paradox of movement. The mechanical pumping action of walking around the house is successfully utilizing the lymphatic system to flush that inflammatory fluid out of the joint spaces.
Right.
Gentle activity is improving the symptoms, not worsening them.
So we have the prolonged hour-plus morning stiffness, the thick swollen feeling from the inside, and the distinct improvement with gentle activity. We haven't even looked at the joints yet, and we already know what's happening.
Exactly. When you combine over an hour of stiffness with improvement upon gentle activity, you are listening to systemic inflammatory joint disease speaking for itself.
Wow.
The history is giving you the physiological diagnosis before you've laid a single finger on the patient. It's not the frayed rope of wear and tear mechanical osteoarthritis. It is the rusted hinge of an autoimmune inflammatory process.
So what does this all mean? Let's synthesize what we've uncovered today. When it comes to decoding the complexities of the human musculoskeletal system, the history, the nuanced story of how your body behaves over time often beats the physical exam.
Hands down.
Yeah. The exact timing of your morning stiffness isn't just like small talk for the doctor. It is a massive, definitive biological clue. And understanding the mechanics of movement, noting whether a joint hurts more when you fire the muscles versus when a doctor bypasses them,
Right.
that can flawlessly reveal whether the pain is deep inside the true joint capsule or sitting in the soft tissue right next to it.
It really is a masterclass in clinical observation and understanding the why behind the symptoms. And, it leaves us with a rather profound final thought.
Now let's hear it.
When we are sitting in a clinic waiting for a diagnosis, we tend to assume that the ultimate, most powerful diagnostic tool is a $1 million MRI machine or a futuristic, highly complex blood panel.
Right.
But today's deep dive reveals that sometimes the ultimate diagnostic tool is simply the mundane details of our morning routine. It raises a fascinating question for you to ponder long after we finish today. How many other mysteries of the human body could we solve if we simply learned to pay closer attention to the exact way our daily habits interact with our physical discomfort?